What would be the three main things that you could improve in the running biomechanics that would help them to run better and safer?
My three things are thoracic rotation, hip extension, and calf or ankle range of motion.
No pain, no gain saying, and when you have pain, just stop and recover.
A little bit of pain is okay. If the pain is lingering for 10 or 20 minutes after your workout or an hour, that's definitely a warning sign that there's something going on and we need to address it.
Efrem is a sport and exercise physiotherapist and the founder of P.O.W.E.R Potential with over 30 years of experience in private practice and professional sports, including national teams in both Rugby League and Football. His main areas of expertise are in the prevention, diagnosis and treatment of sports injuries, movement analysis and exercise prescription.
If you incorporate collagen in your treating practices for athletes and everyday runners?
I think it's absolutely critical. The type of collagen that you recommend is critical, so that's why I love your product so much.
Thank you. Can you tell us what are the most common injuries in novice runners and how can they be prevented?
The most common injury in running is...
Welcome to Chief Life, the podcast that cuts the crap with science-backed insights on health, nutrition and performance. Get expert advice, actionable tips and everything you need to take control of your health and live your best life. Let's get started. Hi Efrem, how are you today?
Hi Veronica, how are you going?
I'm good. I'm so happy that you found the time for the Chief Life podcast in your busy schedule.
Thank you very much. I'm very excited and it's a pleasure to be here.
I'm super excited. I will let you introduce yourself, but before I do it, I'll have to tell everyone that Efrem is my physiotherapist. He is next door to the Chief Nutrition HQ at the P.O.W.E.R Potential in Alexandria. And I am seeing Efrem for my running injuries because he's got all the tools to assess my running and to help me recover, which is why I invited Efrem here today to chat about everything running and running injuries related. So welcome, Efrem, and please introduce yourself to us.
Thanks, Veronica. My name's Efrem Bungarich. I'm a sports APA titled sports physiotherapist. I've been in the business for about 35 years. And I've had the privilege of working with some of the best athletes in Sydney and in Australia. I've worked a lot in the sport of football, starting way back in the 80s and working through the National Soccer League and then eventually getting a spot there in the A-League with the Western Sydney Wanderers. And I've also had the pleasure of working in Rugby League as well. So I worked in the NRL with the Cronulla Sharks and I've worked in athletics. I've worked in the world of professional boxing, professional tennis, with the general community. So I've been very privileged and very lucky to be working with some amazing athletes like yourself, and I get to use my skills and showcase the clinic and use all the sports science that we have here for the benefit of our patients. So I've been very lucky.
Yeah, well, I don't know if you're so lucky or so hardworking. It's a very impressive portfolio. And I must say that your clinic is amazing. For those who've never been there, it's in Alexandria and it has everything that any exercise physiologist or athlete can dream of. You can do VO2 max testing, you can do running assessment, like a biomechanics running assessment, which is very detailed. You can do all your strength testing, and then you also have recovery space, which is why I go to you because of you and your skills, but also because of all the equipment that it's there to use to assess and everything. So most sports involve running and you deal with athletes, which is why you're so good at assessing running and helping with running related injuries. Can you tell us what are the most common injuries in novice runners and how can they be prevented?
Yeah. So with novice runners, it's actually quite common, the difference between novice and seasoned runners as well. So they're mainly soft tissue injuries, and they're mainly related to tendons and bone. So you can pretty much list anything from the toe right up to the low back. When it's bone related, it's a bone stress injury, and it's very common to have metatarsal stress fractures or navicular cuboid stress fractures. It's common to have bone stress reaction in the heel bone, the calcaneus. The most common, and I'm pretty sure that it's the most common injury in running is medial tibial stress syndrome, which is a tibial stress fracture. But you also have bone injuries in, at the patellofemoral joint, where you may have some bony edema and stress fractures of the lumbar spine. So they're your main kind of bone-related injuries. From a soft tissue perspective, then we're mainly looking at tendons and fascia. So that is the plantar fascia, the tendons of the big toe, so your metatarsalgia, and then moving more posteriorly, you've got your Achilles tendon. So Achilles tendinopathies are one of the most common injuries. Second to medial tibial stress syndrome is your Achilles. Third, and it's arguable, depending on which research paper you read, the third would be plantar fasciitis. So it's either Achilles tendinopathies or plantar fascia. Then you have your patella tendinopathies, hamstring tendinopathies, as in your case. And then you have your muscle disorders, so muscle strains. And again, the classification system for muscle injuries has come a long way too. So we can talk about that later if you like, which I find interesting because I'm boring.
Yeah. No, it's not boring. It's interesting. It's a lot of injuries, but you mentioned the medial tibial stress injury, which most people will know as a shin splint. Is that right?
Correct. Yeah, that's
so
right.
how you said that's the most common injury in novice runners. How do we develop shin splints, and what can we do to prevent them?
Yeah, okay. That's a great question. So one of the things you're going to hear me talk about a lot today is load. Now, load can be many different things. Load can be, probably the most obvious thing is I've put on weight or I've lost weight. That's load. It could be that I've increased my training program, or I've increased the kilometers because I want to do the city to surf. I've got 4 weeks left. I need to increase my training. So you double your kilometers, you double your sessions through the week. That's a massive increase in load. So when you factor in load plus your running biomechanics, then it places increased stress on the tibia. So I might actually demonstrate with my ruler. So your tibia, when you hit the ground, your tibia is typically in this kind of angle where when you compress it, it's quite solid. But if you overstride, if you take a really big step and your heel lands really far out in front of you, every time you land, your tibia goes through a bow as it lands. So you get this repeated cyclic loading of the tibia, and that stress eventually causes, bony edema to form within the tibia bone, and then you've got your bony stress fracture. So it's typically a bone stress injury because of repeated bowing of the tibia on heel strike. So if you've got poor heel strike, or if you don't really absorb energy that well when you land, then you get that stress going up through the tib, and then you're prone to having that kind of injury.
Yeah, that's interesting. Can the tibial stress, or like the shin splints, also develop when someone starts running too much too soon? I experience with my clients as an exercise physiologist and running coach that people get fitter, like cardiovascularly in their lungs very quickly, but the ligaments and tendons don't follow as quick. And people think, I don't get puffed anymore. I can run 10K every day because, it's so easy. And then they develop the shin splints because it's too much load and the ligaments and tendons need longer time to adapt. So if we talk about the muscles getting stronger and our cardiovascular system getting fitter, how much longer do the ligaments and tendons take to adapt to the running and the impact of running?
Yeah. Well, again, we go back to that word I said before, load. It's all about load. So again, load can be not only the increased intensity, but the frequency, as you said. The other thing we need to think about is your recovery time. So your training is the stimulus. That's what stimulates adaptation, but your recovery is when adaptation occurs. So your body will grow, your ligaments will adapt, your tendons will adapt during your recovery time. So what you do during recovery is critical. So it's one thing to think, I'm feeling good, my cardiovascular system is on fire, my VO2 is great, I want to increase my running. But if you do that too quickly, then that sudden increase in load can cause the tendons and the bones to become reactive. And reactive normally means that there is some enzyme that's released, and it's typically called pro-inflammatory cytokinase is released, and that cytokinase irritates nerve endings and causes pain. So it's actually a warning sign from the body to take it easy and reduce your load. The trick is, we need to provide enough stimulus to produce adaptation, and the trick is not to exceed the threshold, the tissue threshold, and that's one of the biggest challenges in professional sport. When I was working with these professional teams, you would, at the Wanderers, we had meetings every single morning with the coach and the S&C staff, and we would look at the kilometres of what the players did before that, but not just how many kilometres they did, how much of it was high speed running, low speed, changing directions, acceleration, deceleration, all these factors are critical when we're trying to determine the cumulative load that's gone through that player, and are we providing enough stimulus to produce adaptation and they're getting stronger and fitter, or are we overcooking them and we're exceeding their tissue threshold and they're starting to break down and we're getting all these injuries. So it's a real balance. You need to be smart. You need to train smart. Even though you feel like you have the capacity to go further, just respect the body and understand that they need to be progressive increments. And probably for me, most importantly, really respect your recovery time and what you do during recovery to allow your body to adapt to your new load.
So what would you recommend to someone who is a novice runner for recovery?
Yeah. Great question. So I would recommend that I think we need to kind of figure out, first of all, what are they able to do and what stress did that place on the body, and then we can calculate what is our recovery based on that. So if it's a novice runner, I would say you'd be probably starting at 2 to 3 times a week of running, and you'd be doing maybe 40 to 50 minutes of running in those 3 sessions. And then during your recovery, you'd want to eat well, sleep well, hydrate well, and do active recovery. So active recovery means massage is good, that's passive recovery, but active recovery is actually better. So stretching, foam roller, walking through some cold ocean water, using the plunge pools, so contrast bars, cold plunge, hot plunge, cold plunge, hot plunge. Saunas are great as well for recovery, and any sort of active recovery. So, walking, stretching, exercise bike, that kind of stuff is good as well. So that's what I recommend. I highly recommend that. It's really important to do that also because we need to stimulate the tendon. We need to stimulate adaptation within a tendon, and to be able to do that progressively is critical. If we rapidly increase load, then the tendons get cranky quite quickly, and then they become reactive and painful, and then that kind of throws your whole running program into disarray.
Yeah, so just throw away the no pain, no gain saying, and when you have pain, just stop and recover.
A little bit of pain is okay. You can work through a 2 or a 3 out of 10 pain, but when the pain becomes a 6 or a 7 or an 8, if the pain is lingering for 10 or 20 minutes after your workout or an hour, or that you're waking up the next day, you've still got that pain, that's definitely a warning sign that there's something going on, and we need to address it.
Yeah. Okay, so if we have a novice runner, you said the most common injuries are the shin splints, patellofemoral issues, and plantar fasciitis, This is usually because of increased load. What would be the perfect program for this person in regards to like running, strength training, recovery, nutrition, to prevent these issues from developing to start with?
Yeah, well, if we follow ESSA guidelines, that's 150 minutes of exercise a week of moderate to high intensity exercise for your cardio, and at least 2 sessions of resistance training a week. So if we follow those guidelines, and that's pretty much what we recommend within our clinic as well. So it could be a brisk walk or a jog walk. I think preferably a jog walk combination is good. You can work out some sort of interval training. I think interval training is great for cardiovascular fitness, and I think that's the best way to get the quickest results is with interval training. So you need to figure out the patient's age and figure out what is their max heart rate, work out a percentage of what you want to work in that max heart rate, and then fluctuate between say 60 to 80% of their max heart rate, and we would do that say for 45 or 50 minutes, and try and do that 3 days a week, preferably on flat surface to start with, so on a nice soft football field or on grass, and then we would then implement our strength training. So the strength training would be twice a week. And again, what I would do initially is target the muscles that are involved in the sport that you're doing. So if we're just doing running, let's have a hamstring, gluteal, calf, quad, and a core focus initially. And then we can implement, upper body stuff maybe the 3rd or the 4th week of the program, and just keep changing it, keep adapting, and keep the patient engaged, or keep the athlete engaged, but also look at areas that need to be developed and keep developing, keep changing, keep adding exercises.
Yeah, so for the areas to be developed, would that be smart for every novice runner to come and do the running biomechanics assessment and strength assessment?
Yeah, I think so because prevention's better than cure. So if we can get in and see, restrictions in thoracic rotation, if we can see stiffness in the hip joints, if we can see that they're overstriding or that they're offloading one side compared to another side for some reason, there may be some ankle stiffness, that's a previous injury, a previous operation, something like that that may cause an imbalance. Then once you've done, 10,000 steps a day, or if you've done a run and then you do that every second day and then you 3, 4, 5 weeks down the track, you've got this niggle, and then the niggle becomes persistent at 3 or 4 months. And then there's your running career finished at 4 months. We want the running career to be a lifestyle thing that you can have forever. So let's get in, measure things, find out where the imbalances are, implement a correctives program so we can correct imbalances. We can add little exercises just to strengthen key muscles like your glutes or your calves or whatever you want to do, and enjoy your running. So yeah, definitely prevention is better than cure.
Yeah, I think it's a smart idea. In regards to the biomechanics, if someone comes to you and their running technique is not looking great, but they don't have any injuries and they run a lot, would you try to fix the technique or just let them run the way they naturally run, even if it looks terrible?
Yeah, it's a great question. And there was a lady, and I've just forgotten her name because I was watching it again the other day. She has probably the worst running style I had ever seen. I was watching it on YouTube. She had knee valgus, so her knees were kind of buckling in, her hips were floppy, her feet were going out to the side, and she was kind of rolling her legs, and it was honestly the worst running style I'd ever seen. And she won the silver medal in the Olympic Games at the London Olympics. She was I think she was an Ethiopian runner. So obviously fatigue was a factor there, but I have an old saying that athletes find a way. They kind of find a way to cheat, and I don't mean that they're cheating the rules, but
Yeah.
they cheat. They cheat anatomy. They cheat physiology. They cheat textbooks, and I've seen some people with the worst biomechanics be the best athletes. So I'm very careful when I communicate with athletes because I don't want to come in and say, hey, I'm going to change your running style, because that'll freak them out, and then you'll never see that person again. But I prefer to say, I will improve your running style, or we will make you run more efficiently. And those sort of terms are less confronting to the athlete, and they love to embrace anything that will help improve their performance. So that is really the goal of what we do. We're not trying to change anything, but if we can improve their performance to some, in any factor, even 10 degrees of hip extension may translate into 1 meter of distance as a sprinter. So, without even adding one squat or one box jump, they can run that little bit quicker just because we've tweaked something in their biomechanics. So it's all about improving rather than changing. I'd rather use that term.
Yeah, that's amazing. Okay, so that makes me want to ask a question. So if someone is just average Joe wants to run marathon or city to surf, what would be the 3 main things that you could improve in the running biomechanics that would help them to run better and safer?
Okay, well, if it's a an older athlete, so I'll cheat here if I'll make it easier for myself, because that's a big question. 3 things. I'm going to write this down. 3 things.
3 things.
So I would first of all want to know their history. So in their history, how much time have they had off? What is their tendon health basically is what I'm trying to figure out. So if they've been doing moderate activity and their tendons are quite strong and they're healthy, then I would say my 3 things are thoracic rotation, hip extension, and probably calf or ankle range of motion. So these 3 things, I think, if they're free and they're loose, then a person can run comfortably and they can generate good force on foot contact, and they're going to achieve their goals. So if I look at it from a joint range of motion perspective, it would be that, assuming that their tendon health is good. If it's on the other hand, where they say, I was a great footballer when I was 20, and then, or I was an awesome netballer when I was 20, and then I had kids and the business and everything, and now I'm 38, I'm 43, and I want to go and run marathons, then that's a different patient because they were once an elite athlete. So there was some stress on their tendons and then they had a massive download. So their tendons now have gone through a period of degeneration. So now they're going back into sport with a degenerative tendon. And that patient is the flag. That's the one that may go out there and be disappointed with their results, because if they're not firing up their muscles properly, if their glutes are not working properly and they're overloading their proximal hamstring tendon, then they can end up with a degenerative tendon and a partial tear before you know it.
Yeah.
And,
Yeah, but that's what happened with me. But this is really interesting. Okay, so I'll tell you the story because you haven't met me that long ago. So I've been running most of my life, not competitively, but just for fun. And I used to live on the Gold Coast, which is very flat. And I used to run 20 Ks a day, at least 6 days a week. And I never had any issue, never. I was doing that from when I was 23 until I was 30, which is 7 years. And then I moved to Sydney. And in Sydney, and I always used to do also strength training, at least 3 times a week. So strength training, running 20K a day, no issues whatsoever. Then I moved to Sydney. And I think the hills,
absolutely,
running all of a sudden on the hills, I just started having this ongoing hamstring issue, and it's never left me, no matter what strength training I've done. I also started racing and started doing long distance races, trail races, ultra marathons, whatever. But bottom line, I'm 45 now. I've had this hamstring issue for 15 years and I just haven't been able to recover from it. Do you think I have any chance? And how do I do it? Because I know that a lot of people out there, a lot of my friends who are high rocks athletes, long distance runners, trail runners, some of them are very elite. So many of them have the proximal hamstring issue. And my question is, why do we all have it? What do we do about it?
Yeah, that's a good question. Look, and I have to say, I've seen a lot of women in their 40s that have proximal hamstring degenerative tendons, and it's a similar kind of thing. They've been active all their life and running, and then all of a sudden they take up soccer and they want to kick a ball. So as they're kicking a ball and their leg goes through and their hip goes into hip flexion, there's a compressive load on the hamstring tendon. The other thing is running hills. You will lean forward a little bit more as you're running uphill. So again, there's a little bit more compressive load on the hamstring running up hills. So the fact that you've been running for many years, there's a bit of degeneration in there. So now you're reactive on degenerative. So you've changed something in your environment. So you've changed to running hills a little more than just flats. And that's resulted in the tendon becoming, irritated. And but so what do we do about it? We look at all the factors that may be contributing to your hamstring becoming overloaded other than just running hills. And if we're allowed to use you as an example, a common thing that we see is that there'll be a kind of an imbalance between your gluteals and your hamstrings. So the gluteal, often the pattern is that the gluteal will be a little weaker or a little bit delayed in activating. So the glute really needs to be fired up before your heel hits the ground. It's your main sort of prime mover for hip extension, and then your hamstring kicks in, depending on what part of the cycle you're in and what speed you're running. But typically that's, to simplify it, that's what happens. So then if the glute is a little delayed in its activation, then your hamstring it's working a little harder. And when it works harder and it's tugging on its attachment point, then eventually that attachment point starts to break down and you get the problem there. So what we try and do to reverse that is we try and get the gluteal to work a little better. So you need to do a lot of gluteal training. Now, the tendon will eventually rebuild, and it will rebuild and it'll be strong. The problem is you need to find, as I mentioned earlier, the tissue threshold. You need to find that balance where we're providing enough stimulation to have that tendon, repair, but we're not underloading it and we're not overloading it. You need to find that balance point. And maybe the women in their 40s, I won't say this because I'm obviously the opposite sex and I'm not allowed to talk about women because I don't know what you guys go through. You're amazing.
Fine.
You're amazing.
You can say whatever you want.
But man, when you guys put your mind on something, you really stick to it. So you're such committed runners, and no matter what, no matter how busy or whatever's going on during the day, you've got to get your run in. And they're the hardest athletes to treat because it's almost like you're overtraining or you're kind of doing too much or you ignore the pain. You guys are great with pain, so you push through the pain. I get my elbow into a female hamstring, and I'm like, is she feeling this? I get a guy on there and they're screaming and yelling and rolling off the table, and it's all fun and games. But
Yeah.
women have a different pain threshold, I think, and they just kind of push through it, and that's not always a good thing. You need to listen to your body. So, at the end of the day, what do we do about it? Very simply, strengthen the glute, make sure the glute activates prior to the hamstring, give the hamstring lots of exercise, typically isometric exercises initially, in a position that's not going to cause too much compression of the tendon up against the bone. And then once we initiate some of those adaptations and the tendon starts to get stronger, then we can start to make the exercises more challenging, where you're actually going into hip flexion and you're providing a little bit of compressive load, but not enough to aggravate, but enough to create some strength adaptations. So it's a bit of a tricky balance, and it's really important for the physios to know when to push, when to hold back, what's enough, what's not enough, and what position to put the patient in when they're doing the exercise, to really isolate the key essential muscles that need to be strengthened and not allow the brain to cheat and preferentially recruit other muscles that it's used to switching on, like your hamstring, and bypassing the ones that it needs to activate, like your glutes. So it's a real tricky and it's very complex rehabilitation. Yeah.
Yeah, it is. So with the hamstring tendonitis in a proximal hamstring, actually all the other people I know with that issue are men. They're all runners, triathletes, and high
There you
rocks
go.
guys.
Yeah.
No,
Yeah.
I don't know any other woman in my circle of friends.
Yeah.
But okay, so I think that's very common in runners. What are the other common issues in the competitive runners?
Okay.
Because you
So
said they're
yeah,
different to the novice, yeah?
yeah,
Like novice
yeah,
runners and competitive runners have a
yeah.
little bit different
And
issues.
I
Yeah.
think the competitive runners and the ultra marathon runners, they're more the bone related injuries because they're chronic stress, they're chronic overload, whereas the novice runners are more the soft tissue injuries. So they're like the muscle strains or the reactive tendons or the plantar
Yeah.
fascia. So they're the main ones. So they're much more complex, more bone related injuries, and they're the hardest ones to treat because Mother Nature is the healer for a bone injury. So it's time. We can still provide stimulus and we can still get them to strengthen and do other things, but at the end of the day, you've got to allow the bone to heal, and that takes time. A stress fracture is really a bone insufficiency fracture. It's actually a microfracture of the bone, so you need to treat it like a fracture. It's not like your typical, obvious displaced bone fracture with a fracture line, but there is still breakdown in the bone matrix, and there's still edema, and that all needs to settle before the bone can relay calcium and harden and become normal again.
Yeah. And do you think that women are more susceptible to bone and tendon issues because of hormonal changes? And do you think it gets worse close to menopause?
I think they're highly relevant factors. The other thing that I think we need to also include in that is what used to be called the female athletic triad is now called REDS, which stands for relative energy deficiency in sports.
Yeah.
Yeah. So that's to do with nutritional. So if you're not getting enough nutrition, then you get a reduction in bone mineral density, and then that makes you more prone to bone stress injuries. But again, it's more than that. It changes your hormonal activity. It changes your metabolic rate. It changes so many other factors that are involved now with that, and it affects men as well as women. So it's not just a female athletic triad. It's a complex condition that affects all people.
Yeah. You know what? I have something interesting to tell you. I had the female athletic triad, and
Yeah.
I was eating super healthy. I was studying nutrition and I was listening to what they were telling me at uni. And I struggled. I had osteopenia, amenorrhea for many, many years.
Wow.
And
Yeah.
then I reversed it in my 40s with carnivore diet and taking collagen. And I reversed my osteopenia with the collagen. I recovered my menstrual cycle, and I have healthy menstrual cycle. And it is actually scary because when I was having all these issues, I was having them because I was listening to the nutrition education that was telling me eat the rainbow, eat lots of vegetables, don't eat too much meat, don't eat too much fat,
Yeah.
and that caused so many issues. So I was just wondering if you incorporate collagen in your treating practices for athletes and everyday
Yeah.
runners.
Yeah, I think it's absolutely critical. And the type of collagen that you that you recommend is critical. So that's why I love your product so much.
Thank you.
But when I was at Cronulla Sharks, we had a professional cook that would cook for the players, and I asked that lady to make a bone broth, and just keep the bone broth in a little shot glass, and then they would just microwave it and have a shot of natural collagen. But most definitely, those collagen supplements are critical for tendon health, not just for tendon health, for bone health, for skin, for everything. In fact, there was a paper, this paper, it talks about kind of specific collagen peptides. So that was something I think you might have wanted to talk about at some point as well.
Yeah, we can talk about it now. What do you have to say?
So there was one, and I just need to get the name of it. I'll get the name of it later. But there's a randomized controlled trial that showed that this specific collagen peptide helped to increase the cross-sectional area of patella tendons in patients that had anterior knee pain. So the control group that had no peptide, and then the other group that had the peptide had a larger cross-sectional area for the same amount of exercise. Both did exercise. Everything was the same. The only difference was the peptide. So there's emerging evidence that it definitely does help to strengthen tendons. There's no question.
Yeah, it does. I've read that study. I actually we had to submit and achieve all the science to claim the health benefits of our collagen.
Yeah.
And so I had to review all the literature. So I've read all the articles available, all the studies and everything. And there's lots and lots on osteoarthritis, joint pain, increasing tendon strength, increasing tendon healing. There's actually a lot of good quality science. People just don't know about it, and it really works.
And this specific collagen peptide also is cleared by ASADA. So that's one of the things I checked because, we wouldn't be advocating something that's prohibited. They're completely natural, and, it's just basically pure collagen.
Yeah, it's the same with our products. We get them HASTA tested, and we've got the certificates for the athletes. So all athletes can use our products in Australia without getting in trouble.
Fantastic. Yeah.
Yeah. We've got it all covered. All right, so that's nutrition and training. That was great. The question that I have a lot on my Instagram and from my clients, everyone wants to always know what running shoes are the best.
Yeah.
What do you think?
Well, that's a big question. It's like patients come to me and say, what pillow should I get? It's such a personal thing. And then I tell them, get this pillow, and they come back, I don't like it. So running shoes are a little bit different. So with running shoes, it really does depend on it depends on the person. It depends on the shape of the foot. It depends on whether they're a pronator, so that means they've got a flat arch, whether they're a supinator, if they've got a very high arch. It depends on their body weight, the amount of running that they do. Are they running on hard surfaces, on grass, on soft surfaces, on synthetic surfaces? So it depends on a lot of factors. But for me, the things I don't like in a shoe is I don't really like shoes that have got the massive cushioning. So you see some of them where there's a kind of a convex shape in the sole, and it's really quite thick. The foot really needs to work as an impact absorber. It's a multi-segmented lever system that's designed to, be able to accommodate all different shapes and surface, little undulations, and then we go and put them in this massive shoe with this massive cushion, and I feel like that will reduce our intrinsic ability to impact absorb. So I'm all for cushioning shoes, but not heavily cushioned shoes. I think the things you need to really look for, and again, it depends on your foot shape. So if you have a broad forefoot, so if you've got quite a wide forefoot, then I would go for a sole that is a straight last rather than a curved last. And I would also probably go in a shoe that is a little bit more cushioning, but then put an orthotic device, and we can talk about orthotics at the end of this. The orthotic device will give you that midfoot motion control, but you're also getting the cushioning through the shoe. So it's a good combination rather than going for a heavy motion control shoe, because they're quite stiff and quite heavy. And I feel like they maybe overdo it when it comes to stiffness in the shoe. The other thing I look for is what's called the heel cup. So the bit around the back of the heel that sits on top of the sole, that needs to be firm. So if you tap it with your finger, it really needs to feel like it's plasticky. So what that does is it cups the the heel, and it kind of prevents the heel from rolling. So it just gives a little bit of extra rear foot support, because if you do pronate, if your foot arch does collapse, then the talus bone, which is in the middle of the ankle, will shift medially and your tibia will rotate medially. So you get this calcaneal medial rotation, talus shift, and then tibial rotation, and that puts a lot of stress down the inside of your tibia, and it also contributes to your tibial stress syndrome, and Achilles tendinopathies, because it can cause a bit of stress shielding of the Achilles tendon, and it increases the length of your plantar fascia. So that could also contribute to your plantar fasciitis. So a good heel cup. You want forefoot flexibility, not hypermobile forefoot, but you want a bit of flex in the forefoot. You want good, midfoot support. And I typically like a 1.5 to 1 ratio. So the back of the heel needs to be a little bit higher than the front. Now, I saw a recent podcast where someone absolutely smashed that and said, no, you shouldn't have the heel raised because it shortens your calf and all that kind of stuff. I don't really agree with that. Like, it would really have to be a significant heel raise, and you'd have to be in that position pretty much all day, every day, in order for it to cause a shortening of your calf muscle. So, comfort. Look at your foot posture, look at your foot shape, and then, find a shoe where you feel comfortable in it. Your forefoot is able to spread when you're standing on it. Your toes are not too crunched up against the end of the shoe. You've got good rear foot control. You've got cushioning. If you need an orthotic, get a professional to get an orthotic sorted out for you. And that should be the perfect fit. If you run a lot, then you should, it's recommended that you have 2 shoes, and then you rotate the 2 shoes. So once you've run on a shoe, it needs a good day for the rubber and for everything to reset, or the molecules within the rubber to reset. If you go day to day, then, the theory is that the rubber is still quite, it loses its integrity. So you're losing some cushioning and some supportive role. So if you've got 2 shoes and if you're running every day, rotate them. That's about it.
And how many Ks the shoes last normally? Is it 600?
Look, I'll be honest, I don't know the number, but what I look for stress signs. So stress signs are, if you look at the sole from the side, it looks a bit like my face. It's very wrinkled. So you get the wrinkles in the heel and the rubber. And if you start to see the wrinkle lines going through, and then it's time to change. It's normally about 6 months. If you're running a lot, your shoe will give you about 6 months of wear. If you've got 2 shoes and you're rotating, then you may get that 12 months. But, depending on the kilometers that you're doing, I think if you're a high runner, if you're running 3 days a week and you're doing, 8 to 10 Ks 3 days a week, if you're doing a 30K week, I think you've got about 4 to 6 months out of your shoe. If anything higher than that, definitely you got 4 to 6 months. If you're like me, you might run a couple of weeks and you miss a couple of weeks because you're too busy. Oh, it's raining today. There's an excuse. I'm not going to run. Then you might get a bit more.
Okay. What about carbon plated shoes?
Oh, yeah. The carbon plate, great concept. Great concept. Adds a bit of stiffness, gives you that spring through the carbon. I can't see anything wrong with the carbon, inbuilt carbon foot plate. I don't think there's anything wrong with it. I think it's good. Yeah.
Is it? Because I've heard lots of people getting injured from running in them too much.
Well, it might not be the shoe. It may be the amount of running that they're doing, or all the other factors that are involved. There's so many variables in that experiment. It's hard to prove what's the devil there, So, I like I said, I like the concept. I've never worn them myself. I've never had a patient come in that's had any injuries, because of the carbon. But, everyone, each to their own. Yeah.
Yeah. Okay, interesting. All right. So you have a lot of biohacking tools in your clinic.
Mm-hmm.
What biohacking tools can help to prevent or heal from running injuries, and how? What is the science behind it? Because I think a lot of people keep hearing a lot of things, but a lot of things don't even have any scientific substance behind it. So can you just explain to us what are the best tools and what is the science?
Wow. So, we have infrared sauna. We have a plunge pool that's heated to 36 degrees, and we have a second plunge pool that's heated to 7 degrees. And I'll explain the reason why I've chosen the 7 degree temperature. We also have Normatec the pneumatic compression devices. And then we have an area which I call the active recovery area, which is basically, a floor space with foam rollers and spiky balls. And then we have
And you have the hyperbaric, yeah.
Yeah, and we have the hyperbaric chamber. So we've got a lot of things that are all designed to help basically, remove lactic acid after exercise. A concept that I call neuromodulation. I think they all help change how the brain functions and how the brain perceives pain, and that has its benefits. There are cardiovascular benefits. There are and for me, the most important thing, again, as I mentioned earlier in the discussion, was the difference between active and passive recovery. So active recovery is where your body and your muscle pump is working to pump out some of the waste products of exercise, as opposed to passive, which is really just relying on massage or massage. So the difference between massage and the compression boots is that we're combining elevation, and the compression is a uniform compression where we can calculate the amount of force, and it's applied bilaterally for 40 minutes to an hour at a time. And it's pretty hard to get a massage therapist to do that same amount of work consistently through anterior, lateral, and posterior legs in a position of elevation.
Yeah, that's great.
So we've got lots of tools. Did you want to know about the cold pool, the 7 degree? Why did I choose 7 degrees?
The cold pool, and then also the science behind the hyperbaric chamber and why your one is special.
Okay, so with the cold pool, I chose 7 degrees. Now, typically, there's a lot of kind of arguments about, it needs to be 3 degrees. It needs to be, it needs to be 11 degrees. One thing I do know is that the temperature for women needs to be slightly higher than it is for men, and that's basically because of metabolic reasons. And so I chose a kind of universal number of 7, which is right in the middle. So that way it's a little bit chilled for the ladies. It's probably not quite cold enough for some of the men that they can tolerate. So it's kind of in the middle. Typically you will have 1 minute per degree. So, if it's a 7 degree pool, you've got 7 minutes of maximum exposure before some hypothermia or hypothermic symptoms start to kick in. So what I generally say to my patients is that we would start off doing 30-second intervals. So everything that I do is a 1-to-1 ratio. So it's 30 seconds in the cold pool at 7 degrees. Then they climb out of the pool. They walk into the hot pool. So there's active muscle pump and limbs working through range of motion. Then they go into the hot pool and they thaw out in there for 30 seconds, and then we repeat that. So we're doing 6 repetitions of that, which is 3 minutes, and then we repeat it again. So you're getting 6 minutes of exposure at 7 degrees, but it's chopped up into intervals, and you're getting the active muscle action in between those sets as well. And I find that that's really tolerable for beginners. As you get used to that, you can then increase your duration to a minute and a half, up to 2 minutes. And again, it's the 1-to-1 ratio.
Yeah. Okay, so what is the purpose of going from hot to cold?
Okay, so the purpose is vasodilation, vasoconstriction, which again helps to remove waste products. We're activating the muscle pump, going from pool to pool. The cold also it releases the shock hormones within your body, so it can help with cortisol and other kind of metabolic benefits through that. They're pretty much so that's the other one, the neuromodulation. So when you get into that cold pool, your immediate reaction is that you're like, oh my God, this is so cold, and you're shaking and you're carrying on. And it's just your body's perception of something uncomfortable. It's not actually burning you. It might feel like it's burning. It's not. You feel like you're freezing. You're not freezing. It's just a cold sensation. So when we expose ourselves to that cold sensation, the brain can help to desensitize that sensation. It can help to reduce your perception of pain or something that's uncomfortable. So eventually you can climb into it. You don't breathe heavier. You don't get that same reaction to the cold as you did when you first started. And for me, that's amazing, because that is showing how your brain is changing your perception of this uncomfortable environment. And it does it so quickly. You come out of that, I've never seen anyone come out of it feeling awful or unhappy or not smiling. It just releases all the happy hormones in our body. So it's hugely beneficial, whether it's for mental health or whether it's for recovery after exercise or whether it's to just help kickstart a healthy lifestyle. It's an amazing tool. I absolutely love it. I've absolutely fallen in love with that device. In fact, I used to love going to Clovelly and going for swims at Clovelly and training with one of my mates. And one of the hardest things for me was to get in there and get into the water because it was so cold. Once you've been in a plunge pool for a extended period of time, nothing else is cold. So we went swimming. Yeah, we went swimming last week at Clovelly, and I jumped in the water. It was like, oh, this is amazing. So anyway, the hyperbaric chamber.
Yeah, let's stay with the cold exposure. So I love the cold plunge. I have ice bath at home, and I'm a big fan. I have a really great results from it. But I just think we need to clarify here a little bit because people actually don't understand how to do the hot and cold therapy differently for different purposes. So you explained that it's great for, flushing out the toxins and stuff, but you probably wouldn't do the cold plunge after strength training.
Yes,
because it would compromise your strength gains.
Absolutely.
And I think that's where a lot of people get confused. Like they're like, when do I do the ice bath? So to my understanding, you do the ice bath either as a hot and cold therapy outside of your training, or you do the cold plunge after endurance training to reduce the inflammation, but you wouldn't do it after strength training. 100%. After the strength training, you rather do the hot to increase the growth factors. Right?
You can do that, or what I would do is eat. I would start bringing protein into the body as quickly as I can and do the cold plunge on the next day. So definitely not after resistance training. I love Huberman. I listen a lot to Huberman. I think he's a very intelligent man. And they did studies where they looked at just putting hands into cold water before they did resistance training. And they found a 6-time increase in the amount of weight they could lift just from doing that, because it was changing it was initiating neuromodulation. It was changing how you recruited muscle fibers. That was just an experiment. And so what they were actually doing was they were getting cans of soft drink and freezing them and then holding onto those cans before they did their sets. And they found incredible changes in their strength. So, look, I'm not telling anyone to go and do that as an experiment, but definitely after resistance training, I do not recommend cold plunges. But after any prolonged cardio, after a game of football or netball, or you've gone for a run, or the day after your resistance training when you're feeling a bit stiff and a bit sore, your body would absolutely love the contrast program.
Yeah, I just wanted to set the record straight because I'm really going crazy with all the misinformation, especially on Instagram, and everyone is an expert and everyone has got their opinion. So now you heard it from a real expert. Now we know what to do. Okay, let's dig into those hyperbaric chambers.
Yeah. So hyperbaric started many years ago, where deep sea pearl divers were just living these amazing lives. And if a deep sea pearl diver had a bruise on their body and they went diving for their pearls and they come out, the bruises were gone within a couple of days. And they realized that there's something about this phenomenon of being a diver and having this amazing health. So then, they started investigating. So they found that by increasing atmospheric pressure, we were able to manipulate how our blood is transported across the membrane, the cell membrane. So, to keep it kind of simple, red cells are kind of smaller than your platelets and your white cells. So under normal atmospheric conditions, red cells can pass across the membrane barrier quite freely, but it's a little bit more difficult for white cells and platelets to pass across. So then the concept of hyperbarics is to progressively increase atmospheric pressure, simulating being submerged underwater. And by increasing the atmospheric pressure, we're able to force more white cells and more platelets across the membrane barrier, and we're combining it with 100% oxygen. So the benefit of getting oxygen into damaged tissue and getting an increased number of platelets and white cells into that tissue is it has an enormous benefit for healing, particularly soft tissue injuries, bone stress injuries, patients with diabetic sores that are not healing, any sort of lymphedema. There's some good evidence coming out now that patients that are suffering lymphedema post chemotherapy are getting benefits from hyperbaric treatment for the reduction of their lymphedema. Also, there is cancer-related whole body edema that happens as a result of side effects from their chemo and their radiation therapy, so that the hyperbaric is also good to help with that as well. It's a part of the picture. The good thing about our unit is that it goes to 2 atmospheres. Most of the hyperbaric chambers out on the market only go to 1.3 or 1.5. So the difference there is that I follow the European consensus for hyperbaric medicine, and they get together every couple of years and they convene and they do their research and they present all their papers on what's the best practice for hyperbarics. So they recommend, and most of the research that I've read on hyperbaric, they look at a minimum of 2 atmospheres, between 2 atmospheres to 3 atmospheres, to get a therapeutic effect. Anything less than 2, you're really reducing the efficacy of the whole process. So you really need to have a 2 atmosphere hyperbaric chamber in order to get a therapeutic effect.
Yeah, I've read it as well. I've also read somewhere that the 1 hour in the hyperbaric chamber of 2 atmosphere equals to 9 hours in hyperbaric of 1.3 atmosphere.
Yeah, and that's exactly right. Yeah.
So you're saving a lot of time by having the stronger one.
Yeah, that's exactly right. And you need that strength, you need that force to enable the cells to pass across the membrane. You think of it, if you've had an injury now in modern sport, if you've got a like a tendon injury or a ligament injury, you go to the sports physician will inject you with platelets. So they're actually they're forcibly injecting platelets into the injured area. So you're getting this massive dose of platelets. And again, there's amazing evidence that platelet-rich plasma injections into soft tissue injuries just increase the healing, because platelets have an affinity to collagen. They love collagen. So if you look at a platelet under a microscope, it looks like a snowflake, and it has an affinity, so it will stick to the collagen, and it will help to strengthen collagen, and it also helps to create an inflammatory response within the joint, which also helps to bring out all the body's natural anti-inflammatory agents to help reduce inflammation, help reduce pain. So there is evidence behind PRP. There's also similar evidence behind hyperbarics, where if we increase platelet supply to an injured area, we can get these same kind of benefits.
So would it be the best to combine the PRP with the hyperbaric and the collagen supplementation?
Well, I haven't read that, but I would probably say, and I'd have to put on my physio hat here and say that I probably wouldn't recommend that, because then we don't know what's doing the benefit. You know what I mean? But if I put on my hat where I really want to get the best of everything, then sometimes you can layer it and try and get a combined result. So I won't say that it doesn't work. But
if it works, you don't know what worked.
Exactly. It's probably best to pick one of them.
Yeah. And so for someone like me with the proximal hamstring tendonitis, how often do you think I should do the hyperbaric?
I would say, just from my own clinical experience, so this is not based on any studies, I would say you would do twice a week for an hour at 2 atmospheres. Yeah.
Okay. Done. When I come back from holidays, I'm there 2 days a week. I need to get this sorted.
Yeah. And that would be for a month. Now, you see, the thing here is that the argument is, if she just did exercise for that month twice a week, then you'd probably get similar effects. Whether the hyperbarics enhances your effects, that's the thing that's difficult to prove. Now, it doesn't mean that it doesn't happen. It just means that it's hard to prove. It's hard to prove that clinically. How do we get 200 women exactly like you with exactly the same injury, and 100 of them will get the hyperbarics plus. The other guys will get the placebo treatment, and then measure cross-section area, measure all these other things at the end of the study, and prove that group was better than that. That's the difficult thing, but it doesn't mean it doesn't happen, because when I see patients, so anecdotally, we see changes in patients. We see people that come in, and we can measure changes in their the limb circumference. We can measure increases in their strength on dynamometry. We can measure all these things, but we just can't prove it.
Yeah,
Yeah.
we will have to measure before and after because I have not run in 2 months now.
Yeah.
I've been doing my training, all my physio exercises most days. I've been doing strength training at the gym 3 times
Yeah.
a week. I've been taking collagen, I've been doing peptides, and I'm still not right. So when I come back from holidays, I'll do the month of the hyperbaric 2 times a week and
Yeah.
see if that makes any difference.
Fantastic. And we're going to do some ultrasound guided dry needling into that tendon as well.
Sounds good. Well, that was amazing, so helpful for all the runners out there. And I have last 2 questions that I
Yeah.
ask every single of my guests. If you could give one advice that can be physio advice, health advice to all the runners out there, what would that be? And what is your favorite book? And it doesn't have to be health related.
Wow. Well, I'm a nerd, so I'll answer question B first. My favourite book is Grey's Anatomy because it just brings back good memories of when I was a physio student, and it was such a beautiful book. Its illustrations were amazing, and the way that they described anatomy in that book it's like reading poetry. So I actually absolutely love Grey's Anatomy. Obviously, the most famous book is obviously the Book of God, but outside of that, I'd say Grey's Anatomy. Advice to runners, my advice to runners is just enjoy it. Just get out and enjoy running. Be smart because you want to run forever. I get a lot of friends send me messages, oh, bro, I did this and I did that. And I'm like, man, that's great, but do you think you could sustain that for the next 15, 20 years? So think of it like, I want to do something for the next 15, 20 years. The benefits of running are unbelievable. The cardiovascular benefits, the benefits for mental health, your tendons, your bone health, your metabolism, everything benefits from running. So do it for as long as you can, but train smart.
Yep. Yeah. That was a great advice. Thank you so much for taking the time to chat to us, and I will see you soon.
Thank you, Veronica. It's been amazing. Thank you so much.
Thank you. Bye.
Thank you for listening. Let us know in the comments below what topics interest you, and don't forget to follow us.